So the things I'll be covering today in this presentation, there's three main points. The first of which is what kind of care is available in the mental health care system. There's different levels of care that we talk about. What does those actually look like? What do they kind of do at each of those levels? As well as how can you actually get your teen in the door somewhere to receive help? Many of you probably know because maybe they're already there, but for future reference and maybe other people you know, I think it's helpful to know. Secondly, we're going to be talking about the different mental health professionals that work in the system and in our company and what they each do, as well as maybe what those fancy letters mean at the end, right? There's LPCs, LSWs, MDs, RNs, all sorts of letters, and it's hard to keep track of who does what. And so hopefully that will be kind of an easy way to sort that out. And as well as what they do too, because we might not know. Lastly, some kind of expectations that you guys as parents might want to have, getting into the mental health care system, as well as maybe rules and expectations we have of you guys as parents, as well as how you can support your teen at home while they're going through a treatment program with us. And so those are kind of the three sections that we'll be talking about. So if you have any questions, like Kim mentioned, feel free to type them in that chat box. I think I'm just going to save them all towards the end, and then that way I can get to all your questions towards the end of that presentation. But at any point, if you have any questions, feel free to type them out, and we'll cover them at the end. But I tried to be very comprehensive, so maybe we'll answer a lot of them as we go. In addition to that, I also have made a lot of helpful handouts for you guys, because there's a lot of info that I'm going to go over, and it's hard to really memorize and keep track of it all. So you don't need to do that. This is just to add extra info, extra context, and then you'll have reference materials where you can kind of look back on and remind yourself of some of the stuff I talked about here. So let's get started. First of all, what does a mental health care system actually look like? What are the different levels of care? As well as the ones specifically offered in-house through Edward Elmhurst and Linden Oaks, as well as where you can go, how you can get your kid access to help at any point. So first of all, talking a little bit about referrals and placement, I think across mental health care and across the levels of care in our company, patients tend to get placed in programs or with therapists that tend to specialize with the type of issues or symptoms that they're dealing with. Often, if there's not like a specific program like those Kim mentioned earlier that kind of fits what they're dealing with very specifically, they can get put into a general mental health program that covers all sorts of different topics. And that way they still are able to get some help if that program that's very specialized is not available. And those general mental health groups are typically divided up by age. So teenagers will be with teenagers, young adults will be with young adults, adults will be with other adults. And again, it's the program and therapist that tends to be the best fit. And this is done through referrals and assessments, which we'll get into here in a second. We also have a really cool initiative in the last couple of years that started up called the True North Initiative, and this is a program that essentially identifies circumstances where people have been placed or referred to, programs or therapists that might not be the best fit for where they're at with their symptoms and what they're, presenting with. And so that's meant to get them to where they need to go to get the best help. And it's been pretty successful at getting people where they need to go if there's ever, little hiccups, because, we're not perfect. So sometimes it's about correcting the mistakes versus preventing them. So in terms of assessments, this is kind of how you would get your foot in the door anywhere in mental health, generally speaking. And so you would go to a center where you get assessed, and based on what you report, the symptoms, the history, other kind of factors that they ask you about, that's where the assessor can kind of look at all the different, locations that we have, where might be the best fit given what you're presenting with. And then you get placed again where the best fit might be. At our organization, we have a really helpful office called the Assessment and Referral Center. And so we have a location of that at the inpatient campus, as well as a few of the outpatient sites where you can actually go in and get assessed. inpatient's cool because you can pretty much go in at any time since it's a 24-hour care facility. And there they would do their assessments and get placed wherever is most appropriate. Again, more info on all of these services is provided on those handouts. So getting into the different levels of care here, first of all, we have outpatient therapy. And this is the lowest level of care, meaning the one where the symptoms that patients are coming in with tend to be the least severe, least concern, not that many crisis or urgent things going on. And so what outpatient therapy is typically for is maybe working on kind of long-term growth and healing from whatever patients might be struggling with. It also can serve as a great way to maintain any progress that has been made. Let's say if a patient has stepped down from higher levels of care and then gets referred to an outpatient provider, that way they can kind of maintain some of that progress and even grow a little bit more. But again, this is for non-emergency, kind of working on long-term things that, the patients aren't in danger at all. So that is outpatient therapy. Typically, they would meet once or twice a week at most. They can even meet less if it's not needed quite that often, every other week or every month. And so you just meet around an hour with a therapist there. The next level up, so that's where the symptoms might be a little bit more intense or severe, are called intensive outpatient programs, often shortened to IOP. And so these are half-day programs, meaning that they last, 3 to 4 hours on Monday through Friday. And the idea with IOP programs is they're meant for people that are really struggling with daily functioning in some way, that kind of need a little extra help, support getting back on track. It also might be, where they're facing a little bit more of intense symptoms than someone in just outpatient therapy, and they might need help kind of managing those symptoms and finding alternatives that are healthier for maybe some of their behaviors. So the benefit of an IOP program over just outpatient therapy is that it provides kind of a longer-term environment, right? 3 to 4 hours, 5 days a week, where patients can get support in the moment if they needed it. And there's also, at least in our company, a very holistic healthcare team. In our company, we even have medical providers like doctors, psychiatrists, and nurses that are involved with their care. I will say not every IOP across the country has that medical portion. Sometimes they're just strictly mental health and they won't have doctors and nurses necessarily. But ours being affiliated with the Edward Elmhurst Hospital System, we have that benefit. And so they really kind of deal with different aspects of your adolescence mental health, including like psychiatric medications. They might need any like physical symptoms, right? The nurse might talk to them about those. And then obviously on the therapy side with their therapist, and I'm a skills coach. So we all kind of work together to provide a really holistic care team. And they also get, more psychological education about what they're actually dealing with and what the science says about it, which is not necessarily something that a lot of outpatient therapists spend a lot of time on in therapy. They're more to process and kind of help you cope and manage with things long term. But they don't so much focus on the education science component as well as like skills sometimes. I will say there are therapists that do focus on those things, but not all of them do. So we do offer that, and I think with therapy and those other two components, they can really learn a lot about how to manage their symptoms very well. Another thing with intensive outpatient is patients at higher levels of care tend to step down into it before discharging and getting set up with an outpatient provider. The next level of care up from intensive outpatient is the partial hospitalization programs, also known as PHP. And so they're, again, a level of care higher than that. The symptoms are maybe a little more intense, more severe than the previous levels we've talked about. And so these are full day programs. And so it says 7 to 8 hours, correction. They're more like 4 to 6 hours typically, those full day programs, depending on the organization. And so with that additional time comes more time to get support in the moment if necessary, as well as additional skills groups where they learn more ways to kind of manage their symptoms and how they're feeling, as well as more info, right, psychological education. And so patients at this level of care are either stepping down from inpatient, which we'll talk about in a bit, and kind of as a transition step to get them back into their daily lives, or maybe even residential once they've stabilized, or perhaps they admit directly to this level of care if, say, they're dealing with maybe some more urgent, potentially mildly risky, dangerous things. For example, if they have suicidal ideation, but not necessarily any plan or intent on acting on that, or maybe some like drug use, things like that that might be a little more dangerous. We put them sometimes at PHP, so they get that extra support right off the bat and kind of work to get them back out into the world, even stepping them down to IOP first. And so, yeah, typically the people here have more significant struggles with their daily functioning as a result of what they're dealing with. Next up, we have the inpatient level of care. So this tends to be one of the highest levels of care that we see. And so patients admitting here tend to be dealing with kind of crises situations or dangerous situations that they need very close monitoring and support for. So this is typically when they are a danger to themselves. Maybe they're recovering from withdrawals from substances or kind of getting stabilized if they have some sort of eating disorder. And typically the priority at inpatient is getting the patients there safe. And so they're constantly supervised. It's a 24-hour care facility. There's always staff there. And so they're constantly being monitored for safety, making sure nobody's doing dangerous things. In addition to that, they also do learn some skills to kind of manage themselves while they're there. The idea at inpatient overall is to get them stabilized enough to then get stepped down into PHP and get them back out into their lives eventually. So they tend to not stay here too long. Really, again, it's about getting them stable enough to where they're not going to be a danger to themselves or other people. Or in a medically dangerous situation. And so they typically board at inpatient until they've met criteria for that discharge. And typically it has to do with that safety piece. We also, in the mental health care field as a whole, have something known as residential treatment programs. And this is the one level of care I will specify that we do not offer as a company ourselves at Linden Oaks, but we do partner with a lot of residential treatment programs either in the area or in the region that we have good relationships with, that we do refer people out to if we think it's appropriate, given what they're dealing with. And so the residential level of care is for patients that maybe have gone through the traditional inpatient to PHP to IOP track, and maybe they're still kind of struggling. They haven't really necessarily implemented a lot of changes and still need extra support. And so the idea with residential is they board there and have, a very structured, safe environment where they have time and space and support to start really implementing those things that they've learned and applying them to their own lives so they can really self-regulate and manage their own circumstances and feelings and emotions. And again, it's to make sure that they get that extra level of support, because sometimes if we get them back out into their daily lives too early before they're ready and they feel like they have enough tools and resources to self-manage, they end up struggling and then they might come back. So that's kind of where residential falls. The level of care here is somewhere between inpatient and PHP in that maybe they're not quite as severe the symptoms that they might be having as they might if they get admitted to inpatient. But it is also like a boarding kind of situation, right, where they stay there until they meet the criteria for discharge. And so that is kind of what residential treatment looks like. Last but not least, we have like a psychiatric unit at emergency rooms. And so particularly at bigger hospitals throughout the country, maybe not every hospital, but a lot of the bigger ones tend to have a psychiatric unit. And this is for patients who might be coming into the ER with some sort of psychiatric related emergency. So these could be things like a suicide attempt, maybe it was an overdose from a substance, maybe it was a pretty intense self-harm circumstances. And so the idea here is to get patients kind of medically stabilized, with access to everything that an emergency room would have. Because sometimes even, say, with like a substance withdrawals, say with alcohol, someone's been drinking a long time and they suddenly stop cold turkey, can actually be deadly sometimes. So with that extra added level of medical support, the idea is to get them physically, medically stabilized enough to then get placed in an inpatient program and continue kind of the mental health psychiatric portion of their care. And they don't typically stay here too long. Again, as soon as they're stabilized, we tend to try to get them into inpatient placement as fast as possible, so they can kind of continue the work there. But yeah, if there's any questions with that last section, feel free to ask them in the chat, and I will circle back around to them towards the end. So the next section that I wanted to talk about, excuse me, I'm going to get some water, is what are the different mental health care professionals in the field? What do they all do? What do all the letters mean? And as well as what is a therapist? So that's what we'll talk about next. So first of all, we have behavioral health associates, which is what I do. And so I've been doing this since I graduated college. And so typically behavioral health associates, sometimes known as BHAs or behavioral health technicians, we all typically have a bachelor's degree in psychology or some sort of related field. We do a broad range of work in the field. So often, say at more residential levels of care, which is what I used to do, or inpatient levels of care, we might provide support and monitor patients in what's known as the milieu, which is kind of the common area, like a hospital setting where there's a bunch of people there, just to make sure, everyone's being safe because they're boarded there and they stay there. Everyone's being safe, there's no conflict occurring, and nobody needs any additional support and help. And so that's kind of what we do at those levels of care. And then at other levels of care, so what I do now at my partial hospitalization / intensive outpatient program over in St. Charles is we teach coping skills or psychoeducation in maybe group settings, even one-on-one sometimes. So that's what we do. We're not technically therapists. I'm not licensed to conduct therapy yet, but I am working on it. Next up, I wanted to touch on what is a therapist, because we hear that word a lot, but it's hard to really know what that is, what a therapist actually is. And so really it's an umbrella term, a catch-all term for anyone that can conduct psychotherapy that's licensed to be able to do that. And typically it's by state. And so that includes a lot of different professionals. It could be counselors, social workers, interns, psychologists, psychiatrists, can all technically be considered therapists. So that's really more of an umbrella term. But I am going to go into all of those roles, so we will be more familiar with those shortly. First of all, we have licensed professional counselors, their letters being LPC. Sometimes they have an extra C, LCPC, and that extra C just means clinical. And when it's a licensed clinical professional counselor, they have done some extra kind of education, they've taken a test, and they've had extra hours of supervision, and what that lets them do is actually supervise other LPCs that don't have that LCPC. And they can also do their own private practice with the LCPC level. And so that's really the only difference, but they do kind of the same stuff. So all professional counselors tend to have a master's degree, and they're licensed to work in the states that they got licensed in as a therapist. And so they conduct various kinds of talk therapy that they kind of learned about in school, and apply all of those to one-on-one therapy, as well as group therapy, sometimes in more group therapy-oriented programs. And we already touched on the LCPC. Next up, we have licensed social workers, also known as LSWs, and they also have the same kind of thing as the LCPCs did, in that they have an extra C in their name when they have done some extra education and supervision. They are able to supervise other LSWs or do their own private practice with the extra clinical title. They also have a master's degree and are licensed to conduct therapy in their state of licensure. In addition to their therapy, though, social workers tend to focus on some extra kind of areas. Often they focus on socioeconomic factors as well as cultural factors, kind of broad scale issues that might also influence someone's mental health struggles. And so you might find them working not only in kind of programs like ours or as therapists, but even in like Department of Human Services or Child Protective Services as case managers, because they have that extra level of like cultural awareness, let's say. But they do very similar things as our counselors too. So those are the social workers. Next up, we have graduate school interns. And so these are people who are in grad school, typically in their last semester or two, that are doing their internship rotation, where they kind of work under the supervision of an LCPC, LCSW, or higher kind of degree to get supervised hours so that they can then get licensed themselves as an LPC or LSW. So they have to have a certain amount of hours to get that licensure. And so they have all the same theoretical knowledge of different kinds of talk therapy that a therapist would, because it is towards the end of their schooling. Really the thing here is they're trying to get extra practice applying that in a clinical setting. One thing with these is I've had, interns as my therapist before too. Just because, they don't have their license doesn't mean they're any worse as therapists. Sometimes they're just as good or even better as licensed therapists at conducting therapy. They're really just trying to get the practice to get that license themselves, though. Next up, we have psychologists, and so these have a PsyD or a PhD, and this is like a doctoral level degree. They've gone to doctoral school, graduate school, and so on the PhD side, so that's a Doctor of Philosophy in Psychology. They tend to focus more on conducting research and maybe doing work as faculty in some sort of higher level learning institution like a college or university. Maybe they do research for them. And then there's a PsyD, and so that's a Doctor of Psychology, and so they're more focused on clinical application of psychological concepts. And so the PsyD tends to focus on what are known as assessment batteries, which is like a collection of different assessments that can help them diagnose certain conditions, certain disorders, maybe more accurately than just their clinical judgment. So that kind of sets them apart from all the other therapists that we've mentioned, in that a counselor or a social worker can't really do those assessment batteries because that's not what their schooling was about. However, both the PhDs and PsyDs, psychologists, can work one-on-one with patients. They can be therapists. I believe even the PhDs can do the assessment batteries. They might need to do some extra training. I could be wrong on that part, but they have a lot of overlap in what they're able to do. It's just kind of what their school focused on. They can also do talk therapy just like all of the previous ones that we mentioned. And because they're kind of a higher level doctoral degree, they can also work in supervisor roles, overseeing other LSWs, LPCs, even the clinical ones. They can oversee them too, since the doctoral degree is a little higher than our clinical social workers. Next up, we have psychiatrists, and so they're kind of the odd ones out in terms of all the therapists that we'll talk about, in that they're not just going to school for psychological stuff, in that they're also medical doctors. So their letters are MD or DOs, meaning Doctor of Medicine or Doctor of Osteopathic Medicine. And so they have their doctoral license and degree in addition to kind of knowledge on psychiatric disorders. Because what they did in their schooling is they did a psychopharmacology rotation as part of their doctoral rotations, and so they have a lot of knowledge on like how does psychiatric medication influence the body, the brain, how does it interact with other drugs in order to best prescribe and manage medications with patients. And that's usually what they specialize in, especially in a program like ours where we have different people working different parts of the therapy and their progress. They tend to be more focused on the medical side and prescribing and managing those. That's not to say they can't do therapy, which is why technically they could be therapists, because as part of their rotations, they are kind of informed on a lot of different therapeutic approaches, and they could do it. However, in the field, what we see typically, the way that insurance works is they spend more 15, 30 minutes working with patients on how to manage their medications and prescribing new ones, and that tends to be their focus. But there are some here and there that do take extra time and do some therapy as well. Because they're doctors, often they also work in supervisory roles, so they can actually oversee psychologists, LSWs, LPCs, all of the other therapists, and me and myself can work underneath psychiatrists a lot of the time, so we often see them in supervisor roles. So the next few roles that I'm going to cover are not technically going to be considered therapists, but we also do work closely with them in programs like ours. So I wanted to kind of touch base on what those are too. So another common one you'll see in the field are physician's assistants. And so their main focus is on prescribing and managing medications with patients. The thing with physician's assistants, though, they only went to a master's level program and they did some kind of doctoral kind of residencies rotations, allowing them to actually prescribe meds and manage them. And so the thing with them, though, is they have to work underneath the supervision of a doctor or psychiatrist at all times. They cannot practice on their own because they're assistants. However, with physician's assistants, they don't typically conduct any therapy because that is not part of their training. They're mainly just another access point for medication, prescriptions, and management. Next up, we have nurses and nurse practitioners. Our programs are great because we are affiliated with hospital systems. So we often do have a lot of nurses, sometimes nurse practitioners around. And so in our programs, nurses tend to monitor vitals, making sure, everyone's stable physically, medically speaking. They might also keep track of any physiological symptoms patients might be having with their, what they're dealing with, as well as maybe some medical side effects that they then keep in touch with the providers with. And they also respond to kind of any in-unit emergencies that might happen that need kind of first aid, nurse kind of assistance, and so they're there to kind of step in to help any of those crisis situations. Some of their letters might be like RN, RNAs. There's also the PMHNP, which is a psychiatric mental health nurse practitioner, very long acronym. But nurse practitioners go a little bit above and beyond what a nurse typically does in that in addition to their undergraduate nursing school and licensure, they go back for graduate school and they kind of do a similar thing to PAs where they go through some extra training, maybe some residencies to be able to prescribe and manage medications, just like a PA would. The difference with a PA, though, is a nurse practitioner actually has a little extra leeway in that they're also nurses, so they can do all the nurse duties in addition to manage medications and prescribe them. And if they're like a psychiatric mental health nurse practitioner, they might actually have the ability to do some psychotherapy on their own. The one catch with these nurse practitioners is they have to work underneath the supervision of a psychiatrist or doctor as well. They cannot practice on their own typically. Last but not least, we also often work with dietitians and nutritionists, and so they're often involved when we deal with patients that have extreme depression, anxiety, maybe feeding or eating disorders. And even with depression and anxiety, we see, a lack of motivation, lack of energy, and that might make it hard to really get to meals and get yourself fed. With anxiety, something that happens when you're stressed and in fight or flight is your hunger cues won't actually go off. So there's no way to know that you're hungry. Sometimes you're not even able to digest things because your system's not worried about that. And you almost need to work through some of that anxiety and that stress to be able to adequately get that nutrition. And so our dietitians deal with the nutrition aspect of these things. And they kind of help patients, identify what is a healthy meal plan for myself. How can I manage maybe some of my symptoms that I'm having as I go to eat meals and manage those, regulate them for myself. Because One of the things that we know from the research is that when you have a lack of adequate nutrition, it actually gets in the way of, things like going to school and retaining all that info and knowledge, and going to therapy and actually working through all of these things. It's going to be less effective until they're adequately fed and get all their nutrients. So we do tend to rope in dietitians when that has some involvement with what they're dealing with. And so we really believe in a care team philosophy in that we all kind of deal with a different part of patient's treatment and work together as a team to best facilitate and make that very streamlined for patients. Because otherwise they would have to, talk to their therapist over here, talk to their doctor over here, their psychiatrist over here, and getting all those parts to talk to each other and work well together is a little bit more tricky. So as a care team, we tend to do that just in and of itself, and it makes it a lot more streamlined for our patients. Very comprehensive. As parents and guardians, though, you guys are also part of that care team. We want you to be a part of it as kind of the external supervision and external support from programs, because when they're with us, that's who's providing the support and care. But at home, we're not really there to support them, so that's where you guys come in. Getting into the last section, then again, if there were any questions with that last one, feel free to type them out. The last section then is maybe some expectations to have getting into the field about like what the field entails, things that you can do as parents or things that we expect of you guys as parents, as well as like what are some things you can do at home to help your adolescents while they're going through a program. So as part of our care team, like I mentioned in that last slide, we really want you guys to be involved as part of their treatment. And so what this might look like is kind of being attentive to how your teen is doing at home, communicating and your observations of their behaviors, their symptoms that you notice to their therapist and the rest of their care team, because that can really inform our treatment. Because like I said, we get them for a good chunk of the day, but we don't see them, the rest of the evening and in the weekends. So we're not really sure what goes on, and hearing that from you guys can really help inform how we go about treating what they're dealing with. One thing to be aware of with your involvement in the care team, though, is our goals as a care team might differ slightly from your goals and expectations that you might have of your kids as their parents and guardians. But they do often overlap, because our goal is to get your kid feeling good, getting, mentally, emotionally stable, and giving them access to tools and resources that they can use to help themselves feel better and regulate their own emotions. So we really push that self-sufficiency piece. And that's kind of our goal in being a part of their care team, and you guys might have some slightly different ones. And that's okay, and I think we can often work really well together, but that's just something to kind of keep in mind. Next up, and this is kind of the big legal thing that we see in the system, and this is known as HIPAA, the Health Insurance Portability and Accountability Act. And so it's a broad range of different legislation that protects your patient information and privacy. So what that does, it means, nobody off the street could go into your doctor's office and ask your doctor for your medical info, right? And it's the same in mental health care as it is with, your primary care physician. It kind of protects everyone's info. And this is also true for your teens and adolescents. So one thing with that is that you might not necessarily have access to every single little bit of what they do in their treatment program. And so there is a way to be informed of all of those things, but your teen actually has the option to specify what they let you in on in terms of some of the parts of their program. There is one big exception to this, though. Anything concerning their physical safety and well-being is reported as a legal and organizational requirement. But the reason we do have some of the other stuff more confidential is to provide like a layer of trust. And so this is in the event that, there are unfortunately circumstances where we get patients that are maybe in more abusive or not necessarily healthy home environments. And so they might feel less able or willing to kind of share that with us so we can get them the help that they need if they know that the people at home are going to know about it. And so kind of having some of it be more confidential gives them the opportunity and the confidence to know that, they can share pretty much anything and there's not going to be any judgment or repercussions necessarily. It's not, to keep you guys from knowing things about them and their treatment. Obviously, it might be a cause for some anxiety and concern, but there are ways to, without breaking the law, circumvent this barrier, and that's just to have your kid, specify the access in the ROI. And this is up to them, but by building up a rapport and good relationship with them, they might be, more willing to do it of their own accord, right? Or if you ask nicely, they might just do it without much of a fight. But that privacy really equals comfort in being able to talk about whatever. And sometimes it's hard stuff that we keep inside, right? And not talking about it can prevent us from giving them the best care that we possibly can. And that privacy really helps us bridge that trust gap. One thing with this is that adolescents and teenagers are all required to have what's known as a support session with a trusted adult, parent, or guardian. And so they're required to have the session. What they do have some leeway in is who they have it with. So, they can choose, hey, I'll have it with mom, I'll have it with dad. Let's say it's one of those unfortunate cases where their home environment's not the greatest. Maybe it's with grandpa, aunts, uncles, but some sort of trusted adult that can kind of be a guardian for them in bridging that support at home, even when they're going to discharge from program, right? I will say with these support sessions is it's not the same as family therapy. We're not here to solve all the problems in the home. What it is, though, is an opportunity to touch base with your kid's therapist and their care team and really see what they've kind of done in program, what progress they've made, how you can actually more specifically support them, as they're discharging, getting back to their daily lives, and help them at home in continuation of what we've done in the program. And so that's what those support sessions are for. And again, I think building that good rapport and that good trusting relationship with them is a good way to make sure maybe you're the one that's going to be at that support session. And some of the stuff I'll talk about here in a bit might help build that rapport and that relationship with them. So now we're going to talk about some things you can actually do to help your teen while they're at home, right? Or even, into the future while they're in program and beyond. And so one of the things that we can do as parents is work on our own vulnerability and humility a little bit. So in terms of vulnerability, what we see on our end, both adults and adolescent patients that come in, is that they tend to feel pretty isolated and alone in struggling with what they're struggling with or feeling the way that they're feeling. And often this is just a lack of seeing it in their environment. And so they see all the people out doing their things and not having necessarily the issues that they're having, and so they feel isolated in that. And so by being more vulnerable as a parent, you can kind of bridge that gap, because often what we see with parents is there's this maybe idea or conception that you should have all of your things kind of figured out, take care of your responsibilities and what you need to in terms of being a parent or guardian, so that you're not putting any burden on your kids, which is great, makes all the sense in the world. But sometimes what that leads to in treatment is they see mom and dad, kind of handling all their things, and they're like, mom and dad, my guardians, they don't really seem to have all these struggles that I'm struggling with, so they're not going to understand. And I think sometimes just being willing to be more vulnerable with them and be like, hey, I'm a human being. We all encounter challenges and struggles and issues in our lives. And I figured out ways to deal with them, and you're not alone in those struggles, can really help them feel, like they're not alone, and like they, you might be able to understand where they're coming from. And that helps them actually feel more comfortable and able to take care of their own struggles in a program and beyond. And another thing with humility is, your kids getting into a program, working with all sorts of professionals, and they might be dealing with a psychiatric disorder that you might not be fully aware of, how it works, how to best go about dealing with it as a parent, how to manage it. And so with that comes like a level of trust to develop with that care team, right? These are people that, go to school, medical school, to become therapists, psychologists, all of these things to be able to help. And so they do have the knowledge there. So it's establishing a level of trust in that, your kid is where they're needing to be to get the help that they need, and that they will be able to kind of get those tools and resources to get out on the other end from whatever they're struggling with. And that does require, I think, a little trust in that care team. And you're also a part of it, right? So working with them to kind of maximize the benefits that they get out of their treatment tends to be a good route to do so. So that's not to say, just, hang back and say do nothing. But, feel free to ask questions. Any questions, any concerns to bring up, all of that, I'm sure, will be taken in stride by their care team, and they'll help you understand and know why they're doing what they're doing. So definitely ask questions, raise concerns. All of that is great. One recommendation I will make in terms of additional materials is Brené Brown is a really renowned psychologist these days. She does a lot of work on interpersonal relationships. So if you're interested to see, why is vulnerability so important? Why is it so helpful when I'm vulnerable and when, my teen is vulnerable in a program? She really does a great job at breaking that down in either that book or the TED Talk, and that will be on the extra materials I hand out. But that's one recommendation I have. Another thing that I want to talk about is kind of addressing our own fears, reestablishing trust with our teens, and kind of giving them some slack on their metaphorical proverbial leashes. So I think as a kid gets admitted into a program, let's say they're inpatient with some suicidal ideation or wherever they might be at, there is a very understandable level of anxiety, worry, and fear maybe as a parent, right? You care about them, you love them, you want them to be safe and happy. Makes all the sense in the world. But when we have that level of fear, worry, and anxiety, sometimes the actions that we take and how we handle that aren't necessarily the most helpful in actually getting them to feel better and getting them the help and support that they need. So being able to manage our own fear and insecurity over that, and like I said in the last slide, kind of trusting that they are where they need to be and they're getting that help and it will find their way with enough time and support, is a great way to kind of manage your own anxiety there. In terms of trust, I think with that level of fear and anxiety, and maybe depending on what your kid is dealing with, comes a level of I'm not sure if they can keep themselves safe and kind of manage themselves. And it might be true in some cases. We do kind of go by baby steps depending on the case, right? So they might be working towards being more independent. But generally speaking, we do work on giving them the tools and resources to manage themselves. Because you as parents, us as providers, we can't really get in their brains and fix it for them. So they need to go in and be willing to kind of work through some of that themselves, and we give them those tools. And so by giving them some trusting them that they're going to be able to manage themselves, and maybe giving them a little bit of slack on their leash, right, and not holding them so tightly because we're so afraid and want them to be safe, can actually help foster, feelings of trust in themselves, right? Because if, mom and dad trust me, my therapist trusts me to kind of manage and take care of myself, that means I can trust myself, right? Because if nobody else around me trusts me, it makes me feel like maybe I shouldn't trust myself. Because if I deserve to be trusted, these people would trust me too. And so that really does foster their own independent, self-sufficient learning of all of these things and implementation of those things going forward. And even into adulthood, right, when they're going to have to be independent and manage all those things on their own. Another recommendation here is a TED Talk, again, from Brené Brown on the anatomy of trust. So if you're looking to maybe develop that sense of trust with your adolescent, or that comes up in those relationships or others, she really breaks it down in a very neat, actionable way. I've even used that in my own therapy sessions, and it's been very helpful for me. So we also teach that in our groups to our patients. Last thing I want to touch on is communication, because communication is great, but there are some pros and cons with communication that I wanted to kind of talk about. So it's an important part of developing a healthy parent-teen relationship and in their growth as a person to be able to communicate kind of what their needs, wants, feelings, thoughts, emotions are, right? Because that gets, us all the info we need to take care of them, as well as you as parents, what you need to know to kind of step in and care for them too. However, too much and too little communication can be issues, right? So too little communication between you and your team. You're feeling kind of uninformed and maybe a little anxious because you're not sure how they're doing. And they might also feel a little isolated, maybe like you don't want to be a part of their treatment journey. That's with too little. And then too much can also be overwhelming, stressful, and counterproductive, right? Because stress doesn't really facilitate changing how we feel or changing our behaviors. So we're looking for a kind of a Goldilocks happy medium. So with this, sometimes if you ask them a question, they're like, I don't know. Sometimes that's a valid answer. Sometimes they really don't know, and they might need some extra time to think and process before they can give you a good answer. Another thing that we talk about in programs to our patients is we use around a third of the calories that we eat just to think and problem solve. So when they're in program, they're really thinking and problem solving pretty intense, serious, stressful issues, and so that might even be over that third of our calories, right? So often getting home from program, they're exhausted. They kind of just want to crash, take a nap. And sometimes that's okay, right? They might not be able to give you a good answer. If you ask them, hey, how was your day? What'd you do? They might be like, oh, it was fine. I don't know. Sometimes that's more of a product of I'm exhausted and I don't really have the mental energy to let you in on all this right now. And so maybe finding a good strategy to give them that time and space that they need to really process and internalize some of the stuff that they did in program, as well as rest and recover, in addition to also being able to get that info from them at some point might be helpful, right? There's a way to do both. Lastly, I did throw together some additional resources that kind of cover everything that we touched on in this presentation. So I have one handout on the mental health programs, all the different levels of care, how to get your team help. And that's kind of the part one. I also have another handout on the different mental health providers, all the different letters, roles that they play in the healthcare system, and their level of education. Lastly, for the third part, I have, an info handout that has all of what we talked about, as well as, the 2 books or presentations that I recommended, and some additional info that, on top of what I shared in this presentation, that might be helpful as you're going to care for your teams. And this is all just so that you have access to this as reference, because I did, talk a lot, and there's a lot of info, so you're not expected to memorize all that. So now I'll turn to Kim and see if you guys have any questions that I can answer.
Thank you so much, Gerardo. That was really informative and helpful. I do have a few questions for you in regards to the therapists. Someone asked, can a PsyD psychologist prescribe medication to their patients?
So a PsyD, typically they cannot. However, in the state of Illinois and 5 other states in the country, there is a way for psychologists to go through a special residency so that they're able to prescribe and manage medication. And they kind of function in that capacity as kind of like a PA or mental health nurse practitioner, in that they have to work maybe under or closely with a doctor with supervision, but they are able to do that in like 5 states. Illinois being one of them, and this is because in certain parts of this state and those other 5 states, there's a lot of like rural areas where there's not a ton of psychiatrists readily available to help with these mental health concerns, and so that way there's additional providers in some of these places that can help. But typically they cannot. However, Illinois is an exception to that.
Thank you. And then another question, how often does people in our program see an individual therapist or an individual psychiatrist?
So people in our program typically see them once or twice a week. That's like scheduled. They also do have the ability to request to see them more often, but we do also want them to learn to be more self-sufficient, because sometimes we do have patients that constantly want that level of attention and support. And that might actually be hindering versus helping their treatment. So it really depends on the case, but for every patient, generally it's at least once or twice a week individually for an hour-longish session. And in addition to that, they always have a process group, typically with their therapist, where they're kind of in a group therapy session where they're able to all kind of talk about what they're going through.
Thank you. And then we just had a comment that said, this is very informative, can't wait to get the slides. And I do want to remind everyone that we will be sending out the slides in a PDF copy for everyone that's registered, and also along all of the resources that Gerardo has put together for everyone. So we'll be sure to send all of that out. Again, as Gerardo had mentioned, this is a lot of information, so all of that will also be included in there. And then, again, I will be opening up the poll right now. So if you could please just take a few seconds to fill it. To just answer some questions for our speaker. It's open for about 5 minutes. And then if there is any other questions that we might have missed, but I think I got all of them. But if you kind of think about more questions after this presentation, please don't hesitate to send those questions to Linden Oaks Marketing at eehealth.org right there on your screen. And we'll send that to our presenter, and we can also get those questions answered for you. But I would just like to thank everyone for joining us today, and thank you so much to our speaker for all of this great information, and I hope everyone has a great rest of their evening.